We are live.
A very good evening to all, and welcome to yet another session of Journal Club meeting. We are in the season 4, and we have come out with a topic today which is very relevant to clinical practice, whether the enhanced monofocal versus a normal phonofocal, does it have an edge? So today we have a very elite panelist and which will discuss and dissect this subject very well. And I invite the President BOA to open the meeting today. Dr. Hemalini Samant is the new BOA President, and I ask her to open the meeting. Dr. Hemalini, please.
Hello, everyone. Am I audible?
Yeah, very much.
Okay. Thank you, Dr. Vaishal, for this kind introduction. I think this is a fantastic idea to have these journal club meetings. I'm looking forward to a very insightful discussion. We have some fantastic panelists like Dr. Chitra Ramamurthy, Dr. Prafulla from AIMS, and our very own star, Dr. Saurabh Patwardhan. So without wasting much time, let's carry on.
Yeah, I would invite Dr. Viral Shah to open the meeting on behalf of MOS because Dr. Shirish Thorat is in Greece. Dr. Viral, please.
Yes. Good evening, everyone. Namaste and very well welcome to all of you. On behalf of Maharashtra Ophthalmic Society, I welcome you all to this season 4 of the Journal Club, organized in collaboration with Bombay Ophthalmic Association. Tonight's session promises to be a very highly insightful and clinical relevant discussion on topic that resonates deeply with us all practicing cataract surgeons. This Journal Club platform continues to thrive because of the enthusiastic participation of our young members, dynamic moderators, esteemed faculty, and dedicated committee members. I extend special thanks to our president, our presenter today, Dr. Lavina Paryani, and the moderator, Dr. Sagarika Snehi, both from AIMS Nagpur, for participating in today's Journal Club proceedings. We are fortunate to have with us distinguished a panel of national and state level faculties who bring immense clinical acumen and academic insights like Dr. Chitra Ramamurthy, Dr. Prafulla Maharana, and Dr. Saurabh Patwardhan. A heartfelt thank to our Journal Club Committee Chairperson, Dr. Vaishal Kenya, and Co-Chairperson, Dr. Parul Deshpande Madam, and Dr. Zain Khatib and Dr. Neeraj Israni for curating yet another outstanding academic session. Special thanks to Dr. Sabyasachi Sengupta as our esteemed eminent expert in statistics. I would also like to thank our sponsors, especially Entot Pharmaceutical, for supporting continued medical education. To all our attendees and PGs attending this course, thank you for joining us this evening. Please feel free to participate actively and make the most of this opportunity to engage, learn, and grow together. With that, I hand over the proceedings to Dr. Vaishal Kenya, sir. Thank you, sir, for having us.
Thank you so much for those words. And I now ask Dr. Parul Deshpande to introduce the faculty. Dr. Parul. Okay. Dr. Parul seems to be not online. So I introduce Dr. Prafulla Maharana. He is a very distinguished...
Sorry, Vaishal.
Yeah.
I was not able to unmute.
Yeah.
So,
please.
we have
please.
our speaker, Dr. Lavina Paryani, and we have a co-moderator, Dr. Sagarika Snehi. She is assistant professor of ophthalmology from AIMS Nagpur. Now, for our esteemed panelists, out of 3 panelists, Dr. Chitra Ramamurthy and Dr. Saurabh, I think they are not joining. Dr. Chitra just messaged me because her son is not well. Okay. So we have our panelists as Dr. Prafulla Maharana. And I think, Vaishal, you can be the panelist because you have a very good experience of these lenses. So Dr. Prafulla Maharana, for those who don't know, he's the assistant professor of ophthalmology in AIMS. And I think he's the current secretary of DOS, if I am not wrong. And with this, I think we will go to the proceeding of the Journal Club.
Parul Madam, Vaishal sir. Yeah, we have also got Professor Dr. Pooja Bang Madam, Professor and HOD of AIMS Nagpur. She can also be a panelist for
very much.
Yeah. So I think with this, we asked Dr. Lavina to give a presentation. So Lavina, are you ready? Yeah.
Yes, ma'am.
Yeah.
Good evening, everyone. I'm Dr. Lavina Paryani, a junior resident from AIMS Nagpur. I'm extremely thankful for this opportunity to Dr. Neeraj sir, Dr. Parul ma'am, and to Dr. Pooja Bang ma'am. Today, I'll be presenting a journal club on comparison of visual acuity outcomes of enhanced monofocal versus standard monofocal intraocular lens from a randomized multi-center active control trial. The author is Robert Edward T. Ang et al. The study was published on 1st of April 2025 in the Journal of Refractive Surgery. To disclose, I have no financial interest. Now, cataract surgery is one of the most common procedures performed worldwide, and approximately 80% involve the implantation of monofocal intraocular lenses, which are usually the standard monofocal intraocular lens, which restore the far distance vision and thus have narrow range of field of correction. These standard monofocal IOLs have a single focal point and thus are known to correct the distance visual acuity, and the patient is dependent on spectacles for near and intermediate work. So studies have been done that explore the possibilities of improving the visual function and reducing the dependence on spectacles without jeopardizing the quality of vision, as happens with multifocal IOLs. So in recent years, a new group of monofocals thus emerged called as enhanced monofocal IOLs, which improve the visual performance while maintaining a low risk of visual disturbances like glare and halos. The currently available enhanced monofocals are based on the design, number one, hybrid polynomial aspheric design as seen in Vivinex Impress by Hoya Surgical Optics, or they have a central steepening as seen with Technis Hens IOL by Johnson & Johnson, or they have a small induced positive spherical aberration as seen with Raven Enhanced Monovision by Raymer. The basic principle of an enhanced monofocal is to have an optimized aspheric design where they have a higher order aspheric anterior surface and have a continuous yet a gradual shift in power profile from the center to the edges. This continuous power profile shift leads to extending the range of focus slightly and thus behave like extended depth of focus like optics and improve the intermediate vision along with distance vision. This property of gradual shift in power also compensates for spherical aberration, enhance contrast sensitivity, and improve the image quality even in low light and dim conditions. These lenses continue to be classified under monofocal IOLs by regulatory bodies like the FDA or CE, as they do not split the light into multiple focal points. Now, the objective of the article under study are to compare the performance of enhanced monofocal with the ISO safety and performance endpoint rates, and to compare the monocular distance corrected intermediate visual acuity, abbreviated as DCIVA, of the test IOL, which is the enhanced monofocal IOL, with the control IOL, which is the standard monofocal IOL. The test IOL used here is Vivinex Impress Enhanced Monofocal Model XY1EM by Hoya Medical Singapore Private Limited, which is a foldable single-piece hydrophobic acrylic blue light filtering monofocal IOL with the dimensions of 13 millimeter of length and 6 millimeter of optic diameter and full effective optical zoom. It is delivered via preloaded multi-cert injector system. Whereas the control use is Acrisoft IQ by Alcon Laboratories, model SN60WF. It is again a foldable single-piece hydrophobic acrylic monofocal IOL with dimensions similar to the test IOL. This is the diagrammatic representation of the Vivinex Impress Enhanced Monofocal, which has a standard negative aspheric surface, and the central 2 mm has a smooth variation in the power that leads to extended range of focus and improves the intermediate vision along with the distance vision, unlike the standard monofocal. This is a post-market study where the participants were randomized into two groups where twice the number of patients were taken into the test group than the control group, and bilateral implantation of the IOL was done. It was started after independent ethical committee approval and after written informed consent by the participant. It is a randomized multi-center participant and evaluator mass study, whereas a surgeon knew about the IOL being used. It was conducted at 14 sites throughout 4 countries, including Germany, Spain, Poland, and the Philippines. It is registered at the WHO International Clinical Trials Registry platform and is in accordance with good clinical practice, ISO guidelines, the tenets of the 1964 Declaration of Helsinki, and all other laws and regulations of the country. The eligibility included patients who were more than or equal to 22 years of age requiring bilateral cataract surgery with clear intraocular media, obviously other than the presence of cataract, have the IOL power requirement between +6 to +30 diopters, had minimal and regular corneal astigmatism, and expected post or binocular corrected distance visual acuity was 0.2 logMARs or better. However, people who had intraocular inflammation or had recurrent ocular inflammatory condition or have undergone previous intraocular corneal surgery were excluded from the study. Those who were included underwent 10 visits. In the first, there was pre-op examination of both eyes up to 90 days before the first eye surgery. Then the first eye surgery was done. Then post-op examination of first eye was done at day 1, then at 1 week. Then second eye surgery was done up to 30 days after the first eye surgery, followed by post-op examination at day 1 and 1 week. Then both eyes were examined at 1 month, 6 months, and 12 months after the second eye surgery. The sample size calculation was based upon the post-surgery outcomes. The primary outcome was the performance and safety endpoint rates as outlined in ISO in comparison with the test IOL. And according to it, there should be at least 125 participants, assuming 20% attrition. The secondary outcome was to see the post-op mean monocular distance corrected intermediate visual acuity. And for this, there should be at least 58 participants, assuming 20% attrition. This secondary outcome was based on the hypothesis that mean monocular DCIVA is better in the test lens. The prior results have shown mean DCIVA to be in the test IOL to be around 0.23 logMAR and in the control to be around 0.327 logMAR with a difference of 0.1 logMAR. Now, before the surgery, patient underwent pre-op assessment, including corneal topography and pachymetry, biometry, keratometry, subjective refraction and visual acuity assessment, intraocular pressure check, and pupil diameter was checked. However, the lens power calculation was determined by the investigator's personalized A constant using his formula of choice. Then the surgery was performed using the surgeon's own standard small incision phacoemulsification technique, preferably with self-sealing incisions and ensuring the IOL placement entirely in the back. The outcomes after the results were as discussed previously. Results: there were 172 participants enrolled at the end of the study. However, 164 were studied with 95% accountability and 144 were finally analyzed, with 98 in the test and 46 in the control group. On comparing the demographics between the two groups, it was found that both the groups had similar mean age group of people. Maximum were women with 61% in the test and 69% in the control group, and both the groups had similar axial lengths. On comparing the refractive outcome at the end of 12 months of the study, it was the refractive outcome were comparable with emetropia achieved at 0.5 diopters in 85% in test IOL and around 89% in the control IOL. Now, for the post-op assessment, certain tools were used. One, for visual acuity, MNS Clinical Trial Suite was used, which is a computer-based program which uses self-illuminated ETDRS chart at 4 meters for far distance visual assessment and at 66 meters for intermediate visual acuity assessment. The chart illumination was kept differently for photopic and mesopic conditions as mentioned, and room illumination was also kept separately for the two conditions. The photopic monocular defocus testing was also done using the same chart at 4 meters, and the defocus testing was done using the lenses from +1 to -2.5 diopters, and the visual acuity was assessed in every step by increasing the power by 0.5 diopters. The pupil diameter of the first eye was also assessed using neurooptics infrared pupillometer. Now, talking of the visual outcome, it was found that all the participants within the test or the control group have achieved corrected distance visual acuity of less than or equal to 0.3 logMAR units, which is 100% of the participant in comparison to the required 92.5% ISO benchmark. Then the visual acuity was compared between the test and the control group. And the distance corrected intermediate visual acuity was compared in photopic and mesopic condition. Uncorrected intermediate visual acuity and best corrected distance visual acuity was compared. And it was found that intermediate visual acuity was better in all the conditions, whereas the distance visual acuity was comparable between the two groups, being slightly better in the control group, but this was statistically not significant. The photopic monocular defocus curve showed us that the mean defocus visual acuity was better in the test IOL, where the diopters of defocus was between 0 to -2.5 diopters, and this curve had a peak with a gradual decline. The distance corrected intermediate visual acuity was analyzed in detail using stepwise multiple linear regression model analysis. And the predictors of DCIVA were assumed to be the 5 variables, including sex, age, pupil size, eggshell length, and the treatment arm. However, sex and eggshell length were considered to be non-significant, and this was confirmed with adjusted R-square. Now, as the age and pupil size had positive coefficient and treatment arm had negative coefficient, it was assumed that younger the age, smaller the pupil size, and the use of test IOL had a better distance corrected intermediate visual acuity. The distance corrected intermediate visual acuity was also compared across all the pupil sizes and across all the eggshell length, and the test IOL showed better mean DCIVA across all the conditions. The only catch was that in the third group of eggshell length, who had participants more than 24 millimeters, this result was not statistically significant due to smaller number of participants. Talking of complications, posterior capsular opacification and the need for YAG capsulotomy was slightly more in the test group, but this was stated as not statistically significant. Safety. No cumulative or persistent adverse effects for the test IOL happened that exceeded safety and performance endpoint rate. There were 4 serious ocular adverse events, including CNVM, RD, or sudden loosening of capsular tension ring or increased IOP. But again, these were not judged as related to either of the study lenses. On doing the literature review on the other enhanced monofocals like thickness IHENS, Isopure Enhanced, Ray-1 or Teleon L333, it was found that all these enhanced monofocals have given improved intermediate visual acuity in comparison to the standard monofocal. However, unlike our study, other studies like that on IHENS by Micheletti et al., pupil diameter and eggshell length have played a role of predicting the DCIVA. Also, gender has also played some role in predicting DCIVA, as one of the studies have shown male gender to have better DCIVA, and defocus testing was not the most appropriate endpoint. So the key findings in our study include this randomized trial has met both the primary and secondary output. There were no significant difference in corrected distance visual acuity between the test and control group. However, test IOL definitely had improved intermediate vision under varied conditions. Regression analysis showed that younger age, smaller pupil size, and the use of test IOL were significant predictors of better DCIVA. The intermediate vision were better in all the pupil sizes and across all the eggshell lengths. Concluding the study under MERI protocol, Method, study objective and hypothesis were well defined, but there was no reference stated for calculating the sample size. Inclusion and exclusion criteria were well defined, but no specification on the method of calculation of expected corrected distance visual acuity was stated. IOL specification was stated clearly, but the choice of control IOL was considered a potential weakness. Assignment, there were twice the number of participants assigned in the control group in the test group than the control group, which can confound results. Assessment, study period was well defined, but there were no standardized A constant and lens power calculation formula used across all the regions. Surgical technique was specified, but did the same or different surgeon perform the surgery in the two groups? Post-op assessment tools were clearly stated. Result, control IOL have achieved slightly better best corrected distance visual acuity than the test IOL, though this was not significant. There was no comparison of bilateral visual acuity data stated, and there were higher rates of yak capsulotomy in the test arm, which was alarming. No cumulative or persistent adverse events for the test IOL were noted, and the unique aspheric optical design mitigates the induction of higher order aberration even in the presence of decentration or patient with non-zero angle alpha. However, no data was mentioned on the effect of enhanced monofocal on the depth perception, contrast sensitivity, spherical aberration, dysphotopsia, or glare. Interpretation, robust statistical matching was done, but no patient-reported outcome were mentioned. There was lack of near visual acuity data, which limits the assessment of broader visual function. No data on visual acuity outcome during the 12 months of study period was mentioned. Extrapolation, as the study is sponsored by Hoya Surgical Optics for the manufacturer of the test IOL, the results might be biased. Findings are relevant to routine clinical practice, and a large real-world data set was chosen with diverse demographics, which expands the application. But this results cannot be generalized for all other enhanced monofocal, as only one enhanced monofocal was studied. Now, this article leaves us with the discussion point, should enhanced monofocals become the standard over standard monofocals? And is the improved intermediate vision worth the cost of enhanced monofocals? And would long-term outcomes or patient satisfaction change our recommendations in the future? Thank you.
Very, very crisp presentation. I think with this, we open the forum to our panelists. So we would like from Dr. Prafulla and Dr. Vaishal
And Dr.
about
Pooja.
their coming on this. Yeah, and Dr. Pooja, ma'am, sorry. About the study and its results. So I think we'll start with Dr. Prafulla.
Dr. Prafulla, you are on mute, sir.
Now am I audible?
Yes, yes.
Yes, sir.
So coming to the study part, the methodology, as he rightly pointed, whenever you are planning a randomized control trial, the power of the study is the most important part. But in this study, they haven't mentioned. That is one. Second, if you go through the review part or discussion part, they compared their result with IHAN study, and the IHAN study itself has a larger sample size than this current study. So if somebody calculates the power of this study, now it will not 80%, maybe somewhere around 30-40%. So the study is really very, very underpowered to draw any significant conclusion. That is one point. And second, if you go through the article in the post-op outcome, they have mentioned one significant complication, that is displacement of the CTR ring. So that means there were some cases where the lens were subluxated or journals were weak, and then the IL was put. So that should have been an exclusion criteria. They should have excluded such patients where CTR or any capsular supporting device was put. So that is again, I feel, another limitation of the study. They are not clear about the exclusion criteria. Ideally, only simple catheter cases should have been taken. That is another point. And as such, when some company is sponsoring the trial and the result are in favor of the same IOL, so the result has to be taken with a pinch of salt. So these are the few points that I think goes against the authenticity of the data. I will not say this study is useless, but yes, the data cannot be extrapolated clinically based on this study. Okay, but however, as they rightly pointed out, by the time this study is published, already there are 8 or 10 randomized control trials published on the same subject, and almost all of them have same consistent result. Right. So enhanced monofocal, if we go for the clinical implication, definitely it helps. Everybody knows, whoever uses that, this IL really works. But as the projector highlighted, the effect on contrast sensitivity and glare equity, all these factors they haven't highlighted, and also they didn't uh, take into account the higher order aberrations, which they should have done. So these are the few lacunas. But if you see overall clinical practice or personal experience, I think most of us will agree that they definitely give one added advantage as far as intermediate vision is concerned. But for distance and near, we don't know. And this study has a very those bar charts where you highlighted that the for the control arm, distance vision was better, although it didn't reach any statistical significance. But distance vision was better with the plain monofocal, which even I also feel if you go for an extended monofocal like this, then the distance vision is going to be compromised. And this study statistical significance was not achieved because the sample size was less. Suppose they would have taken 500 plus cases, this could have reached a statistical significant difference in distance corrected visual acuity. So I think these all fact, if you go through the IL manufacturers in recommendation also, they also agree. It gives you intermediate vision, distance vision may be not that optimal. So I think these are my points. Rest of the panelists may comment.
So I would like invite Dr. Pooja to give her comments, please.
Yeah, thank you for inviting me. And firstly, I'll like to congratulate Lavina, and before that, thank the MOS and BOA for including our team for the presentation this time. And Lavina has put in a lot of hard work, and Dr. Sagrika has been guiding her. So yeah, so coming back to the topic, I feel that yes, as Dr. Prafulla said, that uh, there is just a single IOL that is being considered, and the entire spectrum, all the enhanced monofocals that are available, they all have different technology by which they give rise to that intermediate or uh, near vision or whatever extent they do. So there should be some sort of a review article or some sort of a comparison between them. Also, as has been rightly pointed out, the near vision or the contrast sensitivity hasn't been checked. And lastly, if we can just have the last slide, Lavina, the points for discussion, I think definitely, even if some amount of distance has to be foregone, I think most patients would be happier to have a good intermediate visual acuity considering the stress on digital devices. And they would definitely would like to be spectacle free for that distance. Uh, I would like the other panelists also to comment. Thank you.
Dr. Vaishal sir, would you
Yeah.
like to
Yeah,
give
what I would like to say is that apart from the points discussed, there is one point which it's important is the height of the patient. Suppose that is also taken into account, the arm length distance. So that is not being accounted. The other thing which this study looked into was the pupil size. The pupil size was beautifully studied in this study. The third thing is that what is different than the IHANS, then the impressed monofocal is the central element, the aspheric element. The aspheric element is almost 2 millimeters in range, and that occupies a lot of space, especially that is very important in Indian eyes, where our pupil sizes are slightly much lesser than the European or the Caucasian eyes. So definitely in our spectrum, this was the German, Spain, and there was a subset of Philippine eyes also taken into account. But that subset was a very small subset of the study. So by and large, what they have studied is the Caucasian eye population, and more the preponderance was of female gender. I think it was around 61% or 65%, if I'm not right. So what I want to say is that definitely the advanced monofocal definitely gives you a slight amount of edge over the other normal simple monofocals. But what is more important and why it has been adapted so nicely is that the amount of glare, halos, and all which we are having with the presbyopic IOLs is much lesser with these, and the adaptability is much better with the patients with these. So we open this discussion further, whatever questions we have. Yeah.
So, Vaishal, in this study, I saw two things which I was not comfortable with. First, Hoya Vivinex, they have their aspheric monofocal lenses. So why did this study include another company lens and not for primer, the Hoya lens, the Hoya monofocal? I think probably the results would have been better if they would have compared with their primary monofocal lens. And second thing, when you look at the defocus curve, it showed that when you go on a hyperopic side, I think the quality of vision was deteriorated very fast as compared to when you go on a myopic side. So when you look at this, when you are looking at a monofocal advanced IOL, so do you think hyperopia, if it happens in our hands, is going to have a poorer visual outcome in patients where we are implanting these advanced monofocal lenses? So it means we have to be on a minus side or a emmetropic side because as compared to monofocal lens, are we seeing more degradation of the visual quality on a hyperopic side? So if we have a hyperopic surprise, are we going to get a patient who's going to be very unsatisfied or an unhappy patient?
So I would say the other way around. So if you have aimed at a minus 0.5, your distant visual acuity will drop much more than when you are aiming hyperopic plus 0.25. So, you know, in the most of these advanced monofocals, you are doing a micro monovision, most of these patients. And if in the first eye, you have done a myopia, and the other eye, if you still do a myopia, the patient is not very happy with the distant vision because you have a central intermediate element right in the center, even because that is interfering this thing. And if your distant vision is not very great, then it creates a problem. So it's always good to aim for a slightly plus 0.25 rather than aiming for a myopia in the dominant eye. So it is the other way around. And Parul, definitely these hyperopia, if you see at plus 0.25 or plus 0.5, the vision drop in the defocus curve is not that much. But if you go away plus 0.75 or plus 1, the vision acuity is drastically gone down. So
that's what I'm saying.
So we have to aim at plus 0.25 rather than aiming at a minus 0.25 or minus 0.5 in such cases where there is a central element which is having a near focus.
And sorry. Go
I
ahead.
would like to ask something because they have studied the intermediate visual acuity in different pupil size, but they have not mentioned the impact of pupil size on distance visual acuity. So it may have compromised because the central 2 mm is responsible for the intermediate visual acuity. So this may trouble the patient when the patient is driving, especially in the night, and when there is light on the eye and pupil is constricted. So it may compromise the distance visual acuity. So,
not only that, and if you have a myopic correction, it will add to this blurriness.
Dr. Prafulla, sorry, Vishal.
Yeah. Dr. Prafulla, your inputs, please.
No, specific to?
Means
The
The
pupil
question
size.
is,
do we aim for hyperopia or do we aim for myopia?
About this, you mean to say for this extended monofocal?
yes.
Most surgeon would prefer a slight hyperopic because the defocus curve that you get in hyperopia is more patient friendly compared to the myopic eyes. And even if you go by the refraction basics also, they would prefer a hyperopic defocus curve if the intermediate vision is of concern. So I think most of them they prefer hyperopic or maybe metropic.
Very true.
So
And
I
then
just, yeah, I just want request Dr. Sen Gupta to give his statistical inputs because he has to leave. So then we can continue the discussion after
Oh,
that.
sure.
Over to you, Sen Gupta, sir.
Thank you, Zen. So I think it's an interesting article. I'll quickly share a little bit of what I thought is useful. So the study definitely is slightly underpowered to. Yeah, you are able to see, no, my screen.
Yeah.
Basically, the study is overall slightly underpowered. But when you look at the assumptions that they have made, where the distance corrected intermediate vision of 0.23 logmar for test lens and 0.32 logmar for control lens. This itself is a very large assumption of a difference, right? So if you assume a large difference, you will get a small sample size. If you assume a very small difference, you will get a large sample size. So they say prior results, but as Lavina has nicely stated that there is no reference for this. This sentence definitely needs a reference, right? So the power of the study is about 65% or so, which is not ideal. So instead of looking at the power, what we can actually look at is the regression analysis. And the best way to look at regression analysis is to look at the R square values. So R square really means if you repeat this same analysis 100 times over, how many times will you get the same value? And in human studies, it's typically 0.3 to 0.4 R squares are thought to be good. Because even if you get the same regression analysis results 30-40% of the times, it's generally found to be accurate. So let's take a look at the regression formula. And this is what, this is something like a homework for all of you to do. So this is basically the formula that they have derived using regression analysis. And, this is the, this is the table and this is the coefficient and these are the values that they have taken, right? So this is the intercept. This is, just consider this like like the SRK or SRKT formula. So this is 0.228 plus 0.003 into age. So say this is a 70-year-old individual, right? So if you, instead of age, you just put 70. So it's 0.003 into 70. That is 0.21. And, the pupil is 0.065 into pupil size. Say for a typical Indian, it's about 2.5 millimeter pupil for a 70-year-old individual. And then, this is minus 0.122 into the treatment arm, where you put 0 for the monofocal and 1 for the, extended depth of focus, or in this case, extended monofocal. When you do that, you will see that for a 70-year-old Indian male with pupil size of 2.5 millimeters, the distance corrected intermediate vision comes out to be 0.02 logmar. That's almost like 6 by 6, right? The 0.02 logmar is like 0 logmar, So, and for the monofocal alone, it is 0.12. So that's the difference. So how much benefit is it giving to the patient? It's about 1 line, 1 logmar, 0.1 logmar is 1 line. So from a patient's point of view, it is giving them 1 line better in terms of, what they're doing. Now, this is for an Indian patient with 70-year-old typical Indian with a pupil size of 2.5 would get 6 by 6 or 20 by 20 or 0 logmar when you put the test lens, that is the Vivinex Impress. And if you put the monofocal, they will get 0.12 logmar. That is something like 6 by 7.5. Right, so that's like 1 line better. So is it, so I would really like to know from a patient point of view, is this really meaningful enough for them to actually choose a lens which is, which has all these other technologies? But from a patient point of view, just, let's not talk about all the halos and glare and everything else. Is this 1 line meaningful enough from, so I'll just stop my share. So use this formula, just enter values. So when you enter a pupil size of 4, you will see that the near vision for the Vivinex Impress is 0.12 logmar. That's 6 by 7.5. And for the monofocal alone, it is 0.24, which is about something like, uh, you know, it's about 6.6 by 9 or so. So there's really a one line difference that is in intermediate distance corrected intermediate near vision in photopic conditions. Right. So that pupil size really becomes important. So from the Indian point of view, are these lenses really giving us that much benefit? Even in Caucasian eyes, it's giving us one line benefit. In an Indian eye, I suspect it gives a slightly lower benefit. Right. So overall, so just input different values that you can think of. Say 60-year-old man with pupil size of 4, you'll see the benefit is slightly more. And if you put in like a 70-year-old man with a 2.5 millimeter pupil, you will see the benefit is less. So overall, if you do pupillometry, say in all of these patients, we would, perhaps not choose these lenses for those with very small pupil sizes. Typically say we are using a B-hex or something like that. Maybe they will not benefit from these extended depths and these extended monofocals because the pupils are really small and they are anyway going to get in even N6, not just near vision, right? So just use this formula and, this is the only thing which will be really applicable to our daily practices from this entire paper. And, that's pretty much what I thought I'll share with all.
Thank you, sir. So always, you have some really insightful comments which give us a lot to think about. So we'll discuss about what you said also. We'll go back to Dr. Pooja, ma'am. You had something to say before?
Yeah, actually, that was very insightful, really, by Dr. Sabyasachi. So, I wanted to say two things that we always tell our PGs, that be careful when you're implanting a multifocal for a diabetic patient because he may need lasers later on. So, this is actually permissible to be used in diabetic. So, that's another thing, another place where if they are very keen to have an intermediate vision or something more than just distance vision. And at this point, I wanted to agree with Dr. Vaishal because this micro monofocal adjustment, if we can do for one eye distance and intermediate and for the other intermediate and near, if it's good enough, that is not just this one line improvement. In that case, that is the ideal way it is recommended to go about it. But for that, they should have compared the two eyes also, which they have not done in this study. So that was my input.
Thank you, ma'am. So yeah, just coming back to our discussion, and we'll just discuss a few things. So I would like to ask Dr. Prafulla sir and Dr. Vaishal sir, you have a patient in front. When would you counsel for Vivinex Impress or enhanced monofocal? So do you look at the pupil size or something and then decide, or do you routinely counsel for, like a lot of doctors today say that enhanced monofocal is replacing monofocals. So would you counsel like that you don't give an option of monofocal and just think of an advanced monofocal? Do you look at the pupil size? What is your pre-op assessment for these lenses?
Most important is patient's need. If the patient say I do a lot of intermediate work, then that is probably the most important criteria. Pupil size, yes, pupil size do matter, but if I may ask you back the same question, even if the pupil size is 1 mm less or more, but the patient says that yes, I am a hardcore intermediate vision kind of person, like I do a lot of laptop work or all this thing most of the day. So even if pupil size is not within the normal range, you'd still go for a extended monofocal because that is the best option that we have, right? But if patient is saying that ki, no, I do a lot of near work or intermediate vision doesn't matter that much, then in those cases I'll still go for either some multifocal or some monofocal, not this extended, because I feel no matter how much, see, if you go through the history of premium IOs, right? Each time a new lens comes for 1 or 2 year, everybody's like, yes, this is the perfect lens that we have got. But within another year, you'll find another new multifocal lens is introduced, and that will say, okay, previous lens had all these limitations, so we came out with this. So that is what is the point to be taken from this is no multifocal or premium IOL is perfect. right? So single monofocal lens gives you the best quality of vision. That's it. So if somebody is very hardcore about the quality of vision or perfect vision, it's better to go for monofocal rather than going for extended monofocal. For patients with intermediate need, here definitely this is the best option that we have right now.
Vaishal sir, your pre-op.
Dr. Prafulla gave a very crisp and a very straight answer that if you require a very good vision, nothing can replace a simple monofocal. That's very right, because you are not compromising in vision. In my routine practice, I do not measure the pupil diameter at all. And there is no preoperative pupil size measurement correlation with the postoperative pupil size measurements. It's very variable. So there have been no studies which can say properly how much the postoperative pupil size would be. That's one point. So measuring the preoperative pupil size, yeah, it's important, but doesn't help you much. So in my practice, as I go by what the patient wants, if the patient wants more of near and intermediate work, I definitely would offer uh, extended depth of focus lenses. In my practice, I have uh, gone to a hybrid extended depth of focus lens, which is a Lucidus lens, which is a hybrid of a bifocal with the extended depth of focus. And I have replaced my practice with, I have no multifocals I've been implanting for the last 6 years now. So it has worked very well. So to me, either it's a monofocal or either it's a hybrid extended depth of focus lens.
Dr. Prafulla and Dr. Pooja ma'am. So my question is to you, since both of you all work in AIMS. So if you have to, find out the contrast sensitivity for a study purpose or for your clinical practice, how do you measure that? In a center like yours, do you do like a pelliropsin or do you have some other tests that you do for contrast?
Pelliropsin is, I think we at AIMS also we do have that pelliropsin chart. That is what we commonly use. And there is another chart, FACT chart, fact chart, but usually pelliropsin is used.
But is it used routinely for all your post
No, no, no. Only if we are doing some trial or patient is very finicky. But RP center profile is not very unlikely that of private practice. So rarely we do encounter such issues. Most of our patients are satisfied with even extended monofocal, multifocal. That is the advantage of practicing at AIMS New Delhi. But yes, for private practitioners it's very important because nowadays even patients are very notorious. They can file cases also, frivolous cases. I was expecting this. I mean, recently we have one such case. Somebody has filed a case against one of our faculty. I was expecting my vision will be perfect in all the ranges as counseled by the doctor, but I am having difficulty in my reading with this multifocal. So he has filed a case against the doctor ki they didn't inform me properly. There are exceptions, but yes, at AIMS this contrast glare usually we do only for some specific study purposes. Routinely we don't do.
Okay.
And my input would be that again, I come back to the point of having this chair time with the patient, irrespective of where we are working, because this is some kind of message that I would like to send across to my PGs, that they can see it happening where I am counseling my patients, where I tell them about their expected post-op outcomes. And it's very difficult in a place which is teeming with patients, and there are around 300 patients in an OPD with very few doctors around. And so, yeah, definitely. But still, chair time is very important where as far as their visual outcomes are concerned. And most of my patients, they see us doing this, they have learned it. And that is, I mean, we cannot just do away with good chair time. And definitely, patients do prefer monofocal as far as quality of vision is concerned. Also, I try to discourage, because again, it's not a practice, patients who are old enough, and I think that kind of resonates with what Dr. Sabyasachi said. They are quite comfortable with their reading glasses. They're very comfortable. So they want a good quality vision, and they are the ones who are still reading their physical books. So they want a very good quality of vision, and they don't mind using their glasses. So at that age, if I get patients at that age, I am perfectly fine putting in a very good quality monofocal. And expectations have definitely increased even in the government setup. So we have to beware of all these things. Yeah.
I just wanted to point out one more aspect is that what kind of extended depth of focus lenses are we using? Is it based on spherical aberration, or is it based on hyperasphericity or some other technology? Because extended depth of focus lenses based on spherical aberration, the brightness or the illumination in the extended depth of focus area is much, much lesser. So it's a compromise. So whatever depth of focus also you're getting, the contrast is far lesser than the other kind of technologies. So that is another point which has to be kept in mind. And the interplay of spherical aberration which the patient innate has with the extended depth of focus lens. So that also plays a role. So it is better off not to use lenses which have more of spherical aberration dependent extended depth of focus lens, because there is a lot of variability with them, their results.
One more thing I just wanted to ask is that when we look at any of the lens, we talk about even the effects of tilt and decentration on the visual quality or visual acuity when you are dealing with an IOL in a patient. So when we compare this with the multifocal versus monofocal advanced, what effect a tilt and decentration would have on a monofocal advanced lenses? Do we expect it to be much worse as compared to monofocal, or are we looking at only a very mild, deterioration of the visual acuity or the quality of the vision? Any comment from the panelists or those who are,
So if I were to take this question first,
Yeah.
There is a lens known as lentis available of emptis, which is asymmetric poly focal lens. It's not a multifocal, they call it this thing. So just to tell you that this is a progressive lens where already the intermediate zone is decentered and the near zone is decentered. So it all depends on the optics of the lens, but definitely even in a monofocal lens, a 0.4 millimeters more decentration induces a lot of coma and other aberrations. A tilt more than 7 degrees tilt definitely would cause even in a monofocal lens. So definitely with these complex optics, it will definitely deteriorate further more than a monofocal lens.
Yeah, sorry. So I missed the point.
The
So
effect of tilt and decentration
so
on monofocal advanced lenses.
so the if you go through the literature, uh, not much has been analyzed on this part, except a few experimental studies. If you go to the investigative ophthalmology and visual sciences, so what the common interpretation of all these experimental studies is that, in monofocal the vision is perfect. Okay, so in whatever other lens that you use, be it multifocal or extended range, this vision is little bit compromised. So now any tilt will impact both monofocal as well as these premium lenses. But the effect in case of premium lenses where the normal physiology has been already altered, that will be more. So that you can get only by doing a higher order aberration studies, because normally these small little tilts, they affect your higher order aberrations, total internal aberrations. So for that one has to do a study where they will analyze both pre-op and post-op internal aberrations, and then you need a very large sample, because these small tilts, no, it's often very difficult to identify. And when you identify that cases will be hardly out of 100, it may be one or two cases. So you won't reach that statistical significance to say to say conclusively that okay, these lenses have this much effect. So it's very difficult to say, but if you simple trust your theory knowledge, so definitely all the effect will be more augmented in premium IOLs compared to your simple monofocal lenses.
I
Thank
would
you.
just like to make one or two comments. So I think Sen Gupta sir pointed out something that was very important. I personally, in my practice, also feel the same. That Indian pupils being smaller, the pupil itself tends to give a lot of depth of focus. So if you apply the same formula, we will see that the same monofocal lens is also giving you excellent intermediate vision. But the only thing is we don't test it. After the extended monofocal lenses came out, we started testing very extensively. But if we test on plain monofocal lenses, aspheric lenses, they also give very, very good intermediate and computer vision. This is one thing. And second thing is what was not pointed out was that, these lenses, because of change in optics, are definitely going to have some impact on the refraction, post-op subjective refraction. So always considering the distance corrected intermediate vision is not right. We should also look at the uncorrected distance intermediate vision, because these lenses tend to have a lot of irregularities in the post-op subjective refraction. And this study also showed that when you did not take the distance corrected and only uncorrected intermediate, the difference between the monofocal and extended monofocal was lesser. So we are not in real life scenario going to do the distance corrected, intermediate vision. It's going to be uncorrected always. So, where a monofocal lens, a good monofocal lens is going to give you bang on results, extended monofocals are slightly going to vary with the final refraction that is going to come, which is going to affect the intermediate vision. So these 2 points I felt also were
You had a very
important.
valid point. Just like in refractive surgery, corrected vision doesn't matter at all. So in premium lenses also, if somebody is claiming it gives you a good intermediate vision, it has to be uncorrected. That should be the criteria to judge those lenses.
Uh,
Any other questions, comments?
So I think we should just wait for these studies to happen in India and actually see we should not just extrapolate it from populations that are not Indian. That is another takeaway I feel. And also, Dr. Lavina can just confirm that this study did mention somewhere that the tilt didn't matter so much in these lenses. I think I heard something like that one of these slides.
Yes, from they have mentioned that the results did not differ even on decentration.
Okay.
I think we
How
can
much
conclude.
decentration?
No, they did not say.
Nothing more than that was specified, sir. Just the
So
statement was there.
the decentration is not going to impact the corrected visual acuity, right? So they should have analyzed the aberrations that is induced, which they didn't do. So that would have given a clear, indications of how these descents are affecting your quality of vision. Okay, this is the visual acuity that they measure. That is not quality of vision. That is absolute visual acuity that we normally measure. But the quality of measure include all higher interpretation, glare, halos. That they didn't compare.
Doctor, if I just want to ask one more question that currently I see that the monofocals are getting replaced with these monofocal advanced, okay, in majority of the practices. And I also see that patients who have astigmatism up to 1 diopter also, people are implanting these lenses. So do you think that these patients are going to do better even if they have astigmatism up to 1 diopter, they are going to fare well? Or should we recommend an astigmatic corrected either the extended lenses or the monofocal lenses? So nowadays we correct even 0.6, 0.7 astigmatism. So is it worthwhile using these lenses for patients who have low astigmatism? Because I see couple of people, asking these questions, and they categorically say that they use monofocal advanced. So is it the right way to go? You see a patient with low astigmatism, less than 1 diopter. So should we really go with the monofocal advanced? Is it the right way to go?
I
Dr.
don't know
Like,
if
Prafulla,
you If you go through the article, I don't know whether it's a typo error or what. In the inclusion criteria, they have mentioned any patient with more than one diopter astigmatism post-operatively were excluded. And that is what I was wondering, ki how can somebody exclude before doing surgery, presuming that the patient will have one diopter astigmatism post-op. So they have excluded these patients with more than one diopter astigmatism, but I don't know whether it was a typo error or I don't know, somehow they excluded. It may be a pre-op patient with one diopter astigmatism they excluded. That could have been the criteria. There is I think, Livna, you can clarify that. You have gone through that article
Yeah, but
mostly.
less than one
Right.
diopter astigmatism. Should we really implant these lenses? Because there are people who think that
Yes, you
it
can
doesn't
implant.
matter to have a
See, monofocal again will have the same effect like extended. The astigmatism is not going to change in either case. So I don't find any harm in putting these lenses. Yes, the patient has to be counseled. The result may not be that optimal because you have that astigmatism part.
Vaishnav. What is your take?
See, we are more aggressive against the rule astigmatism in low diopters less than 1, and definitely I do correct with the rule astigmatism also 0.6, 0.75 astigmatism, because when you're putting premium IOLs, especially multifocals or extended depth of focus lenses, the near vision gets compromised if you have a residual astigmatism. So you have to have all the light energy directed properly. If it is if your astigmatism is not corrected, definitely there would be a compromise on the near vision.
So the
Zain,
only
what
thing
is
is,
your
if you go through the FDA trial, which approved these lenses, they never approved as extended monofocal or extended range vision. They were approved as monofocal, and the trial, the study results of that FDA trial, if you go through that, they simply behave like monofocal lenses only. So all the rules or the criteria that was used for monofocal lenses, the same applies to these lenses also. The company claims, yes, we give a better intermediate vision, but I think the results doesn't change that much in comparison to monofocal lenses. If your astigmatism may be say less than 0.75 or zero point 0.5, for one diopter, it's always a good choice to go for a toric lens. And nowadays, almost all the surgeons, they feel that ki any astigmatism, you should put a toric eye.
We
I think
can
anything
conclude
is
then.
always
The
Yes.
other thing which I want to point out is advanced monofocal is different, and extended depth of focus lenses give you a more range is different. We cannot mix both of them and club them in the same basket.
But if you are concluding, let me say something, because these lenses are not
yeah.
bad. The amount of discussion that we had, the reader may make an impression that these lenses are not good. These lenses are good. If a patient wants an intermediate vision, you should go for such lenses, except few things that you must counsel. At the ma'am said, no, the chair time is important. You should counsel them ki yes, these are not some magical lenses, but yes, this will definitely give you a better intermediate vision compared to a monofocal lens. I think that should be the point the readers should take away from this. It's not a no for these lenses. Yes, these lenses are good for intermediate vision.
But I think nowadays the patient only comes and tells you that they want near vision and they want this kind of a lens.
That is the best part
I
of
think the
Google.
awareness has become so much. I think it's been used very, very rampantly by everyone.
So we had a good extensive discussion on this topic, and I think Dr. Prafulla and Dr. Pooja have elucidated it very nicely to our audience. Very well, and I invite Dr. Piyush Bansal to give the Thanksgiving for our journal club meeting.
Thank you, Dr. Vaishal Kinia. First of all, congratulations to all of you all, the entire team, you inclusive of Dr. Parul Deshpande, Sunny Sengupta, as well as Zain and Neeraj, who've not only conducted the session wonderfully, but asked very pertinent questions. The only issue is that when you keep asking so many questions, sometimes it leads to a lot of confusion. And for that, we have to immense thanks to give to both the faculty. First of all, thanks to Dr. Lavina as well as Dr. Sagarika, and especially thanks to Dr. Pooja Bang and my dear friend Dr. Prafulla Maharana. I completely agree with all the points that he made, especially the last ones, because to wade off all the confusion that exists, all of these lenses have their place, except that we should know which is the right place for them. So thank you very much for this wonderfully educative journal club.
And we thank the Entored pharmaceutical company for giving us the support for hosting this journal club meeting. And I thank once again all of you. And it was really a good meeting. Thank you so much.
I think thanks to the entire team. I
Thank
think
you.
Ames team and
Thank you to the entire team of BO and MOS.
thanks, Dr. Prafulla.
Thank you. Thank you so much.
Thanks, Indus.
Thank you for the invitation. Thank you. Can we have a group photo if possible? Like, be nice.
Yeah, sure. Yeah.
It's done.
It's done. It's done. Yeah.
Yes.
Thank you. Bye-bye.
Thank
Good
you.
night. Good night,
Okay.
everyone.
Good night.
Bye.
Good night. Good night, sir. Good night.